All right, we are going to go ahead and get started. Hello, everyone, and welcome. We are very pleased to have you for this month's edition of our Pharmacy Access Office Hour. Today, we are going to be discussing creating a patient assistance program for your community health center.
All right, thank you, Olivia. Welcome, everyone. Happy holidays to everyone. I hope you're kind of getting ready and prepared for your family time, safe family time coming very soon. So welcome again to today's Pharmacy Access Office Hours. Focus topic is a repurposing, a revisiting of the Creating a Patient Access Program. You may remember we presented on this topic back in earlier this year in February. So we wanted to make sure we revisited this given some recent inquiries around the same topic. Next slide, please. Yeah. All right. As always, we are to avoid any advocacy-related discussions during this office hours because of the federal funding that we have allotted. And a new item that we have to be aware of is we will not be allowed to provide any live 340B content. So any live kind of responding to questions via Q&A with 340B specific related items, we're not going to be able to do that via the call office hours moving forward. And this is effective the 22nd of November. BIPIC is no longer allowing funding to support that. So putting that out there. So if you have any questions related to 340B, please hold those. And what I will do is I will have Olivia push out some instructions that we received from BIPIC regarding how you can appropriately ask those questions and basically funnels you through the BIPIC team and the HRSA team. So I know a huge change. I know, unfortunately, we're not able to have that live discussion like we normally do around 340B specific topics, but you'll see some instructions pushed via email later on. Okay, next slide, please. All right, very short agenda. So again, welcome everyone. If you're still chiming in, welcome to today's office hours. Again, repurposing the topic on creating a patient access program, and our speaker, everybody knows Tim. So Tim Millett's going to provide us some review of this topic, and then we'll have some Q&A at the tail end. And feel free to pose any questions in the chat or the QA tab. There's a Q&A tab within our session player. So feel free to throw those questions in there, and we'll try to get responses to you as quickly as possible. All right. Next slide. I think we're going to hand things over to Tim. All right, Tim, fire away.
Thanks so much, Brandon. I do appreciate all of you being here today and listening in on this topic. As Brandon mentioned, this was something that we presented earlier in the year, but there's been so much going on with the manufacturers. There's changes that have occurred with patient assistance and often in more of a need, and especially this time of year, it seems, we've got more folks who simply can't afford their medication. So we thought it might be good to revisit this. Before I get into the program, I do want to throw out a request to all of you. My contact and Brandon's contact will be at the end of the slides, but pass on some ideas for office hours. Since we can no longer discuss 340B on office hours, we need some ideas because most of the things that we do combine operations and 340B. So going forward, we need some ideas in order to avoid violating the BIPIC requirement. So let's go ahead and get started with the presentation. So as most of you know, patient assistant programs can be very, very key to health centers. There are health centers that do more through their patient assistants than they do through their in-house pharmacy. I was shocked to find that out, but in fact, because of their population, that's how it works. So patient assistant programs, or PAPs, I'll use those interchangeably today, really help to provide free medication to patients who are uninsured or underinsured. And other ways they can be used is to help folks who do have insurance but simply can't afford those co-pays. So all of the PAP programs are based initially on financial need. And then also it's going to vary with medical insurance. Many of the programs, if you are on a federal program, you can't access their PAP. And it also revolves around medical necessity. Next slide, please. So I know establishing a PAP program can be difficult, and it's time consuming. It requires, probably not a full FTE, but it's going to require a portion of somebody's time. And so getting the resources necessary to get this running can be quite challenging. First and foremost, finding that dedicated staff member to operate this, and also making sure that you've established a really good relationship with your medical department. It's a two-way street with the medical department. We need to get signatures from them for these applications. They need to know that we're available to help their patients and refer their patients to us. So it's a two-way street. While there are hurdles to be jumped in getting a program established, there's also some real upside to it. And one of them is in cost savings that the patients will see. We know that patients will see improved outcomes through adherence and compliance when and only when they have access to their medications. So if we have patients that are taking their insulin every other day because they can't afford it, but we can get them a 90-day supply from the manufacturer, that could have a huge outcome difference in their lives and in financially with the health center. You may see your HEDIS scores improve. So there's some actual hard dollars that can come back to your health center based off of a PAP. We'll also discuss copay assistance cards, and these are for usually commercially insured patients. These can also have a direct financial impact on your pharmacy, where maybe somebody has a high copay and you secondary bill your EPAP or your sliding fee program. That money actually just is lost. So it's kind of just written off. So if they have $100 copay, you apply your EPAP or sliding fee, it comes down to $5. That's great for the patient, but there's a $95 deficit there. With a copay assistance card, that's covered. So we'll talk just a little bit more about that as well in further slides. Next slide. So I mentioned, the first and foremost is finding that person to operate this program. Those of you who are a pharmacist, let me tell you up front, I do not believe that this is a pharmacist's job. There are other things that your unique skill set needs to be dedicated to. But I know at my health center, we had to take one of our star technicians and help put him in this role. So one of the things you need to think about for the person is, do they work well independently? Are they self-motivated? Will they be well organized and have a lot of attention to detail? Those are really key in this program. It does help to have someone that's knowledgeable about drugs and billing. So that, again, would kind of lean toward a pharmacy tech, and also understanding the manufacturers and different insurances. So I can tell you, in some health centers where they don't have an in-house pharmacy or may not have a tech available, MAs have been very, very good at operating this program. There are folks even from financial departments that have had to operate this for health centers that don't have access to these other folks. But one of the last attributes that I feel is super important is that they need to be a truly compassionate and dedicated person, because this population is often difficult to work with. We have to ask them for financial information. Sometimes they simply don't have it. We have to kind of get into more of their personal lives and get addresses and things like that. So combining someone that works well independently and has a passion for our patient population is where you're going to find that best person. They can learn the rest of it, the drugs, the billing, the manufacturers. They need those two attributes especially. Next slide, please. So we've decided we're going to move forward with this program. We need to put it together in a policy or procedure so that we've got a documented way of how we're going to implement it. Now, at my pharmacy, we have one set of policy and procedures that we use just for 340B. Then we have our pharmacy operation P&Ps. I think that the patient assistance program is going to fall directly into that pharmacy operations one. So we need to outline what types of services will we provide? Are we going to limit it to 20 drugs? Are we going to limit it to just uninsured patients? These are decisions that you'll need to make. And as I talk through this, realize you can write a PMP and you can adjust it, you can change it a month later as you start getting into your program. So, sketch an outline and then realize you may be changing that because your processes are going to change as the whole program evolves. So within the PMP, outline how you're going to identify patients. Will you only do patients who come directly referred from the provider? Will you take patients that just kind of walk in and say, I can't afford my med, how can you help me? You'll need to make that determination. You'll figure out how are you going to gather the information. When we first started, my lead tech sat across from the patient in a small, very, very small room we had for this, and typed into the computer their information while she interviewed them. I'll also share online on AutoPod later some forms that folks have used as an intake form. So there's different ways of how you'll gather that. But then another real key, and this is kind of the key to a good ongoing program, is how are you going to track everything? So document that in your PMPs as well. So how will you track when you submitted it, when it came back, when did the patient pick it up, when's it time for renewing it? That you all want to include. Next slide, please. So I mentioned tracking and how important that is. The tracking can be done in a variety of ways. There is low tech, low cost by using an Excel spreadsheet. And trust me, a lot of health centers just track on Excel spreadsheets. There are certain things that you'll want to include on that. We'll get into that in further slides. But there's also web-based patient assistance software. I'll review those in a further slide as well. But they do cost money. I don't think any of them are free. But I think that these are really valuable tools and that you can justify utilizing your 340B savings to purchase and help you more streamline this process. Let's go ahead and take a look at the next slide. And well, this is how you would kind of set up your Excel tracking sheet. So there's things that you need to include. Some of these are going to be very, very basic, like the patient name, their demographic information. I included diagnostic codes because some of the PAP forms do request those. So as you're gathering information, it'd be good to get that either out of your EMR or directly from your providers. The drug, the manufacturer, and then you've got this whole section of dates, which I mentioned previously that are so important. You need to know, when did the patient complete the form? When did you get it back from the provider with the signature on it? When was it sent to the manufacturer? When did the drugs come back? And real important, how do we set up kind of a tickler column that'll tell us we received this December 15th, the patient picked it up on December 16th. So realistically, on February 16th, we're going to want to start the process of getting another 90 days in for that patient. And so to have this column that you can quickly scan and see, okay, here's 3 patients that in the next 2 weeks we need to do renewals on, that's really valuable in order to keep up on everything. This program is wonderful, but it doesn't do any good if the patients aren't getting these medications on that regular basis that they couldn't afford in the first place. Once those medications come in, I think it's helpful to include the medication name and NDC and the lot and expiration date, just in case there's a refill or a recall or other questions may come up about that. Next slide, Olivia. So I mentioned that there's a variety of ways of gathering information. As I said, my lead tech, she sat down and just typed it in. That was the easiest way for her to do this. Others use kind of a standard intake or application form. And one of the things, I believe it was David in Virginia used down in Central Virginia Health Center was an authorization form. And what this did is it authorized the health center to fill out this paperwork, but it also authorized them to sign for them so that they didn't have to call the patient back in to get a signature once all the paperwork was completed. I've got a copy of that to show at the end of the presentation, and I believe I have one that they were willing to share with us that I'll post on Nottopod later. I believe I'll also have kind of a stock reference letter. Oftentimes, if patients have no proof of income, you need to submit something into PAPs. So this letter basically would just explain that the patient maybe is homeless, or they have no income, they're looking for work, they're uninsured, living at their grandmother's house, whatever it could be. This will at least be a template that you could work off of, because they're not going to accept the application without something as far as income. Next one, please. So how does the day kind of work for a PAP coordinator? It really is going to work like most of our days work. We start off reviewing our communication from the day before, from overnight. We're going to listen to phone messages. We're going to look at our emails. If your health center has an instant messaging system, a provider may have sent you an IM on somebody that they want to get into your program. It's real important, once your program is up and running, that you kind of promote it and let your staff know that it's available, what patients qualify for this, and how you can help. That'll be just kind of a self-perpetuating. So again, I wouldn't do this right at the beginning until you get all of your kind of your procedures in order and you're very comfortable with your processes. But at some point, it might be good, maybe even once a year at a all staff meeting, ask for 5 or 10 minutes just to explain what the pharmacy is doing, patient assistance, and how the office, the providers or the MAs or nurses can get a hold of you when they have patients that need you. After going through the communications, you'll want to go to that spreadsheet and see, okay, where are we on the applications? And you can see, you may see date-wise, a bunch of them are stalled at the providers. So it might be wise, run up to that provider and say, hey, I have 4 patient assistant forms that are waiting for your signature. Could you get those signed for me so I can move on? You may see that you've got 2 or 3 folks that within the next few weeks are going to be time for a reorder. So you may need to print off new paperwork and start that process. And then there will be ongoing things. You'll have new patients come in, or you'll have applications in process that you'll need to continue work on. So that's kind of how I visualize it. And as I remembered Sue doing all of this work, that's how her day worked. Now, the beauty of this is you aren't going to have this person usually on a daily basis having to spend half a day just doing patient assistance. There will be days that they may spend half a day. But as I remember, Sue used to go in whenever she had free time. Things were caught up. She'd just jump in and work for 15 or 20 minutes on patient assistance. So realize that it can be done in between other activities. Next slide, please. So I also mentioned that there is software available. And just ahead of time, all of the light green sections in here are actual links. So when you get the slides, you can actually click on those and go in and take a look at these softwares. So they can be a little bit pricey. And as I said, though, this really, I think, is a justifiable price. And it does look good to know that we're using our 340B savings from our pharmacies, whether they're contract or in-house pharmacies, to helping these uninsured patients. I can't think of any better way to use this. And so it also looks good when you put together your one-page impact statement or your use of 340B in your health center, that funding the patient assistance program for uninsured patients to get free meds was one of the ways you use 340B. So I remember when I first put this program together, I reached out and I asked folks to get back with me and let me know if they did use software. So Derek Peel from Kansas let me know about one through WebPath. Suzanne Stewart uses the PAP tracker through Needy Meds. Andrew Gonzalez and Ann Rumbles uses the Med Data. And David Christian and Virginia Robinson, I spent some time with to discuss Virginia Healthcare Foundation and their program called the Pharmacy Connection. While it's entitled Virginia Healthcare Foundation, it is a nonprofit organization. They have a variety of services they offer, but one of them is an excellent pharmacy PAP program. And this is one of those that there is an upfront cost, but the work that they do, I was able to sit through a demo of it, is amazing. And it truly would simplify and streamline your program. I'm not pushing one of these over any of the others, but this was the one I had most experience with. So if you have specific questions, feel free to reach out to any of these folks about the programs that they use. Next slide. Here's a couple of other sites. I can't really vouch for them. I tried to find out about a fee for this product Atlas, but I never heard back when I originally did this. So, and then there was one called Drug Assistant, which is a PAP program. You can look into these, but those on the first slides were the ones I felt I really had health centers that were using and could support. Next, please. So beyond just the standard patient assistance programs, there are other monies out there available for folks in need. There's foundations, there's other organizations that will help patients do these applications. So understand that some of these may charge a fee to the patient. So this is where if a patient gets online and says, you know, I need Ozempic, and somebody will pop up and say, we can help get this for you, but they'll charge them $50 to do the application and track things. So just be aware, not all of these are necessarily free. And so patients may come to you with questions about them. Just be aware of that. RX Assist, Needy Meds is a very good program. It includes both patient assistance and copay assistance and coupons as well. I do have, I think, some examples from Needy Meds on the next few slides. The medicine assistance tool also provides some good resources. Healthwell Foundation is kind of unique. They are a nonprofit organization. They actually will help with premiums, copays, and deductibles. There are a lot of things that are involved in that, but link into that. Take a look, see what they have to offer. I can tell you, about a year and a half or so ago, my father was on a med that was going to be over $10,000 a month. It wasn't going to be covered by his Medicare. We searched and searched, and we finally did find someone that was going to be willing to help him. It took a lot of time and effort, and my whole family, from my mom to my wife and myself, all medically knowledgeable, but we worked for a good 6 months before we could find something. So I didn't know about Healthwell Foundation at the time. So just take a look. They aren't going to be able to help every patient, but I thought it was a good resource. Another company is Patient Services, Inc. As I mentioned earlier, some of these that I've listed do require an upfront fee to do these kinds of applications. That's one of the reasons I think it is so beneficial that within your health center, even if you don't have a pharmacy, even if you're really small, find someone that can get knowledgeable about these programs and assist these patients so they're not paying these fees to somebody else. Next slide, please. So just briefly, I wanted to bring up the topic of discount cards versus copay assistance cards. I know in numerous conversations, hallway conversations at conferences or in sessions at conferences, even here on office hours or on Autopod, we've discussed how discount cards really aren't a great deal. They may help the patient, but the person that gets hurt is the pharmacy. GoodRx comes out ahead, they get their piece of the pie, but we end up often losing money whenever we dispense, and that's even using 340B purchase medications. So I have really strayed away from the discount cards because I couldn't justify it. If I had a patient that was adamant about using one, I would send them to one of the big chain stores because they could afford to lose the money. I felt that we really couldn't. More often than not, patients that were looking at using these cards qualified for our EPAP sliding fee type program, and that's where I would steer them. Copay assistance cards, on the other hand, are phenomenal vehicles for helping folks that have high copays or have very expensive medications. I can give you an example. While I'm not a health center patient, one of my sons is on a very expensive medication. It's $5,000 a month. My insurance covers $4,500 of that, but I have a $500 copay for that medication. The company that he works with, the medication is from, has a copay assistance. They pay all but $5, which is just phenomenal. We are so blessed to have that. But the pharmacy gets that $495. They aren't losing out on that. So it's being paid through the manufacturer. So definitely look into the copay assistance cards. I love it when I have commercial patients that I can use those with. So take a look at some of the sites that were on our previous slide for that, and Needy Meds especially. If we look at the next slide here, I took an example out of Needy Meds for Xarelto. This is a little bit dated, but I'm sure it's still kind of similar. And the reason I threw this up is that the top one is for patients with commercial insurance, and they can get their meds for no more than $10 a month. This is a wonderful deal. The one below actually said it's for eligible commercial or for commercial or government insured. Now, I tried to get more information, but I couldn't, because to get through the process, I had to put in financial info and everything else. But it sounds to me like perhaps if you've got a Medicare patient with very high deductible plans, they may qualify for this second one. And so you're not going to be totally excluded for folks that aren't on commercial insurance. This, again, it's just one of the examples. Next slide, please. Well, this hopefully has been helpful in running through a variety of ways that you can establish a PAP program, how to track it, how to get patients and staff involved. It really is beneficial to both the health center and to the patients. The patients will get the medications they need, and it's really hard to comply to a medication regimen and being adherent if you can't afford it. So these programs help eliminate that barrier, and with improved compliance, we'll see improved outcomes with them. We'll also, as a pharmacy, if we can get copay assistance cards for our insured patients, that steers us away from using our EPAP or sliding fee, and will allow us to provide patients 90-day supplies even through these different programs. One thing I did want you to know, at my health center, whenever we did an application for someone, we did charge them a minimal administration fee of $5. It cost us, I think, $2 or $3 per form. $5 is our minimum EPAP charge. So we felt that that was very, very reasonable, because there is an awful lot of work involved in getting all of it filled out and getting sent in and everything else. But at least the patient did have some skin in the game at the $5 per app. You can decide, you could charge a little bit more if you feel that the process is more involved or you have expenses you need to cover. But I did want you to know that, at least personally, I feel that that's a reasonable cost for one of our patients to pay to get this product. I believe, oh, one more slide, please. I did want to thank Virginia Robinson and David Christian from Central Virginia Health Center. They had a very good program, and that's who I learned about the pharmacy program that the Virginia nonprofit offered. And then Anna and Leslie from Christ Health Center helped me with some information on tracking and some other things. So I just wanted to give a shout out to them and thank them. The next page is a example of this consent and release form. I really like this. I wish we had had something like this because it would have simplified our lives. And I love the signature authorization idea. So I believe that's my final slide. And I have not been able to follow the things in the chat or the Q&A. So I'll let Brandon throw those out if he's been able to.
Sure. Thank you, Tim. And I think great kind of overview and a review of that really relevant topic. There are actually only two kind of questions. I know one was just around the recording of today's session. So yes, I see Olivia answered that. Yes, today's recording, as all of our sessions, will be recorded and available. So you should get an email from Olivia following today's call. So there are couple questions. There's some hands raised too, so I'll get to those too. There's a couple questions. One, so I should preface it as not 340B related, but 340B is mentioned. So the question is, are FQHCs required to provide a sliding fee for contract pharmacies? And they state that we only charge the 340B price of the drug plus a small pharmacy dispensing fee for all uninsured, underinsured that qualify for the benefit, not necessarily tracking poverty line.
Can I answer that?
Sure.
Okay.
Yeah.
This was what actually, we've been talking with some attorneys and others. Ideally, we want to have discounted medications, affordable medications available to eligible patients at contract pharmacies, especially if you don't have an in-house. The pricing that you've mentioned, that makes sense. That's how most health centers I'm aware of do this at a contract pharmacy. The other thing is you are not mandated to have it available at every contract pharmacy. It's impossible because some of the contract pharmacies simply won't do a discount program for your patients. So it'd be impossible to require them to do it if their policy is no. Ideally, find out geographically. Maybe you can find 2 or 3 that'll at least give somebody access to the discounted medications in your primary geographic locations for those folks.
Okay, thanks, Tim.
But no, you don't have to have it for every single contract pharmacy. And yes, the way that you're doing it is like most health centers that I've spoken to, that's how they offer it.
Great, thanks, Tim. Hey, Olivia, I see Ed Hines' hand. I'm gonna let Ed, if you'd like to ask your question, feel free. I think Olivia can unmute you.
Yep, Ed, you should be able to unmute yourself now. Feel free to chime in.
There, am I unmuted now?
There
Yes,
we go.
we can hear you.
Hey, thanks for the topic and the seminar. I appreciate it. I have just, I do a lot of work with patient assistance for our folks. And do you have any tips or tricks in terms of trying to find consistency amongst those that you speak with at the manufacturers? We had a case where we were asked for additional information on a patient, and one person told us we needed it, and then we just coincidentally realized, oh wow, it got approved when we went to send all this documentation that we had gathered. So, do you have any suggestions on that?
Unfortunately, no. I don't have like a list of the patient assistance folks at the different manufacturers. And I have to tell you, thinking of manufacturing, I can tell in a previous life, I worked at Lilly, and folks in those positions rotate constantly. I can say that's one of the reasons I like some of the automated programs is that they stay up to date on what's actually required for these applications, and perhaps they would have those contacts directly. But I'm not aware of an actual listing like that. There could be one out there, but I'm not aware of it. I'm sorry.
Thank you.
Great. Tim, another question that came through was from Susan. Says, do you have any suggestions for patient assistance for health centers who do not have in-house pharmacies?
Yeah, I tried to allude to that a little bit. I can tell you just a regular doctor's office often will work through and do patient assistance for their patients. That's often done by the MA or the nurse. very likely in a regular doctor's office, they don't have the percentage of uninsured or needy patients that we do. So if you're in a health center that doesn't have access, doesn't have a pharmacy, doesn't have pharmacy techs, I would look into finding a really competent and compassionate MA that could potentially start up this program. Perhaps one of your nurses, I know at least at my health center, our nurses are really stretched thin. But you could even find somebody in the finance department, I guess, that could just do the paperwork. You know, generally our finance people are very task oriented, and they're going to do a very good job of tracking, which I've mentioned is so important. I would not choose to simply say, well, we don't have a pharmacy, we're not going to do PAP. You've just kind of got to do a little searching and find that right person that can take that on. And I know for all of us, and this is hard, we're all stretched so thin. There's not a health center, period, that isn't stretched thin. Today I'm up in the Pacific Northwest, and I've been with 2 health centers in the last 2 days, and they're both large health centers, but all of them are talking about their difficulty in finding help. So I do realize people are stretched, but this is a program that is so important to ensuring that our patients get well and stay well. It's one thing to be diagnosed and prescribed, but if the patient can't afford the medication, we've just hit a brick wall. So search out that person with that personality of being kind and compassionate, and at the same time being meticulous and task oriented.
Great. Thanks, Tim. One other question came from Linda Gutierrez. How long does it take to get the medication once a PAP application is sent?
Wow, that's a good question. I know it can really vary. The initial application, I think, could take anywhere from a month to 2 months. But often the renewals, those can go very quickly. And I'm trying to recall, there are some that you may be able to renew online or with a phone call. But I do know that the renewals go quickly, but that's why I said you want to look about a month ahead of time to begin that renewal process for the patient.
Great. Those are all the questions from the Q&A. I see some things may have popped up in chat, so give me 1 second. I'm gonna scroll through. I think Elidoro mentioned or asked the question, do you have a toolkit for starting PAP programs?
We don't really have a toolkit, really just this presentation. I will attach some forms that the 2 health centers were willing to share with me so that you can look at what they use.
Okay. Nashika just asked, I'm going through the chat, you guys, so feel free to fill in context. It says, what if you don't have an approval from Novo Nordisk for a PAP and you try to call them, you stay on for hours? How can you cut this situation down? So I don't know if you want to just mention that.
I can mention, but I have no solution for that. Unfortunately, I just don't. And I know how frustrating that is. I can tell you, that was one of the reasons that Sue at my pharmacy, we got her a portable Bluetooth headset that would connect with our phones in the system, so she could get on hold and start working with patients and doing her other jobs while she was on hold.
Gotcha. Yeah. I see April just made a comment in the Q&A, basically saying application status takes 4 to 6 weeks. She said, I'll call companies around 2 weeks in to check on the application status, and this usually speeds up the application process. Thank you, April. Okay, I think, let's see here, make sure there's no other items in the chat. Yeah, just other additional comments about that point there. So yeah, thank you. Thank you all for your questions you submitted, and Tim, certainly for the great presentation and kind of recapping on this a really important program. I know a lot of health centers are looking at that and trying to kind of refine their programs too. So great presentation. To wrap things up, we're going to give you several more minutes back to your day, but to wrap things up, as Tim mentioned, if you have topics, certainly with the change in 340B that we can talk online, certainly have topics. please shoot those Tim and I's way. So you just saw our email on that slide. Most of you should have our emails already, but feel free to shoot us any ideas that you have or topics that you'd like us to focus on for our upcoming office hours. FYI, February's office hours we will cancel due to the P&I. So there's a overlap with the last day of P&I. So we're going to have to cancel February, but the others will be should be moving forward with all our other months. So if you have any topics, feel free to shoot those our way. And I'm just going to make sure scan of the Q&A just one more time. Just additional comments. All right. Okay. Thank you all. Please follow us. You see our slide there. Please follow us on all the social platforms. We're there. Those are great ways to get additional information from NAC organization wide. We'll push out messages for you on those platforms. And of course, you all mostly are on our NautiPod community. That's also another way for us to get information out. Reminder, at the end of today's call, Olivia will get out the information of the recording information, as well as some evaluation links for you to submit those evaluation responses. All right. We're going to give you about, 16 more minutes to your day. And again, happy holidays to everyone. Please stay safe as you're staying home or as you're going to visit family. We want to be able to see everyone next year in 2022. All right, take care. Thank you. And thank you, Tim.
Bye, everyone.
All right, goodbye.